Good evening, one and all. I warmly welcome you to our sixth CellTalk webinar. In today's session, Ms. Divya Lakshmi Ramakrishna will be presenting research titled Intratumoral IL-12 Delivery Empowers CAR T-cell Immunotherapy in a Preclinical Model of Glioblastoma. Divya Lakshmi is a clinical content writer at Renix. She is responsible for writing scientific content on healthcare-related topics. She also focuses on writing scientific white papers and review articles focusing on various fields of medicine and healthcare with a focus on oncology, neurology, and immunology. Divya has a master's degree in dental surgery, MDS, from the Rajiv Gandhi Institute of Health Sciences. Before joining Renix, she also worked as associate professor at D.A. Pandu Memorial RV Dental College and Hospital, Bangalore, India. At Renix, she has attained operational as well as scientific writing experiences. Her work at the organization involves collecting micro and macro data related to GDP, healthcare, etc., and analyzing that data for research papers for journal publications. So, without further ado, I welcome Divya to take over.
Thanks, Aditi, for your elaborate introduction. So, as you have already mentioned the title of my presentation today would be Intratumoral Interleukin Delivery Empowers CAR T-cell Immunotherapy in a Preclinical Model of Glioblastoma. The original authors are Agliardi et al. Now, this is from the journal Nature Communications and published in the year 2021. Coming to the introduction of glioblastoma, as you are all aware that glioblastoma is one of the most common and aggressive primary brain tumors. The standard therapy consists of radiotherapy followed by concomitant temozolomide chemotherapy. And the recurrence rate is very high in glioblastomas, basically at the margins of the original resection or at local metastasis. It has a dismal prognosis with a median survival rate of 14 months and also an average 5-year survival rate of less than 5%. Now, coming to the background of this research, the treatment with the T cells redirected to tumor specificity with a chimeric antigen receptor are very well suited to treat the intracranial tumors due to its ability to access the central nervous system and also due to its migration to the infiltrative sites. These chimeric antigen receptor T cell therapy has also shown to be very effective, and it has attained complete remissions in hematological malignancies. But the key barriers to the efficiency of these CAR T cell therapy are tumor heterogeneity and also the immune inhibitory tumor microenvironment. The CAR T cell efficacy is impaired by an adaptive immune suppressive response and infiltration of the T regulatory cells. Hence, there is definitely a need for additional therapeutic strategies to counteract the hostile tumor microenvironment as well as overcome the tumor heterogeneity. So, in order to face these challenges, interleukin-12, which is a pro-inflammatory cytokine with a potential tumor suppressor activity, represents a promising candidate for this combination immunotherapy. And these interleukin-12 can directly support the persistent cytotoxic activity of the T cells and also reshape the endogenous immune inhibitory cells within the tumor microenvironment. The systemically interleukin-12 is poorly tolerated, while the delivery via the engineered T cells is also associated with severe toxicity. Thus, there is definitely a need for a delivery method which can achieve the benefits of interleukin-12 in the tumor microenvironment without causing any systemic toxicity. So, the objective of the present research was the use of a single intratumoral dose of recombinant single-chain interleukin-12 fused to the FC portion of the neuron immunoglobulin G in combination with systemic CAR T-cell therapy in an orthotopic syngeneic mouse model of EGFR-expressed glioblastoma multiforme. Coming to the methodology, there are various variables which have been assessed in this particular study, And the first variable was to check the local delivery of the single dose of interleukin-12, whether it improves the efficacy of the CAR T cells. The mice had received 5-gyrate total body irradiation, following which a single intratumoral injection of 300 nanograms of interleukin-12 was given, and the mice were then treated with the CAR T cells which were administered intravenously. And the other group of mice were treated with single therapy separately. The tumor volumes were then measured by using MRI. Now, the tumor volumes which were measured by MRI showed that while both the single therapies with intravenous CAR T cells and the local intratumoral interleukin-12 therapy were only able to delay the tumor growth, the combination of systemic specific CAR T cell therapy and the local interleukin-12 administration, they not only eliminated the tumors in most of the treated mice, but they showed a synergistic effect on the overall survival rate. The second parameter or the variable which was assessed was interleukin-12, whether it reprograms the endogenous T cell compartment within the glioma tumor microenvironment. It's well established previously that interleukin-12 has the ability to activate the lymphocytes in the tumor microenvironment. The endogenous T cells to the brain tumor microenvironment were examined by applying the statistical T-SNE method in combination with the flow SOM metaclustering, and this unbiased analysis identified 3 clusters of endogenous T cells, which were the CD4 T cells, the CD8 T cells, and the T regulatory cells, which are mainly the memory T cells. And the authors observed that there was an increased frequency of these CD4 T cells and a decrease in the frequency as well as the count of the regulatory T cells. And one more important finding was that these effects were independent of the CAR T cell treatment. The third variable which was analyzed was whether interleukin-12 reshapes the myeloid compartment within the glioma tumor microenvironment. The analysis was done to check whether the improved survival observed with the combination therapy was associated with changes in the myeloid compartment as well, which represents a significant proportion of the immune cells in the glioma tumor microenvironment. A multi-parametric analysis, a statistical method, which was combined with the flow SOM metaclustering of the brain myeloid cells was performed. And along with this, the serum analysis of the mice was also done in post-interleukin-12, after post-interleukin-12 administration to assess the systemic toxicity. And the results here showed that interleukin-12 mediated reshaping of the endogenous T cells and the myeloid compartment, which together with the orthogonal effect of interleukin-12 on the CAR T cell function resulted in complete eradication of the glioma tumors. The serum analysis of the mice after post-interleukin administration found that there was no significant higher levels of interleukin in the systemic circulation of the mice, and hence this local delivery of interleukin-12 is accompanied by minimal systemic effects while still providing a significant boost to the tumor control. Now, coming to the discussion, in an orthotopic syngeneic mouse model of glioma, a single intratumoral injection of interleukin-12 combined with systemic infusion of CAR T cell therapy resulted in the eradication of advanced tumors, whereas either single treatment alone failed to control the tumor growth. The combination treatment of CAR T cells and local interleukin-12 administration improved the efficacy of CAR T cells in aggressive and also poorly immunogenic tumors. So within the endogenous T cell compartment also, the present study reported that interleukin administration, it resets the balance between the CD4 effector T cells as well as the regulatory T cells in favor of CD4 effector T population. Also, an increased accumulation of the CD4 effector memory T cells was observed, which suggests that interleukin-12 plays an important role in mediating the infiltration of CD4 T cells. Previous studies have reported that the depletion of these CD4 T cells resulted in complete loss of efficacy of interleukin-12 treatment, indicating that these effector cells play a major role in interleukin-mediated efficacy. Along with the modification of the T cells directly, it has been reported that interleukin can also skew the myeloid compartment towards a pro-inflammatory phenotype. This myeloid compartment plays an important role in the glioblastoma immunosuppression, and the accumulation of immune inhibitory myeloid cells is more prominent in high-grade tumors. In the present study, it has been reported that interleukin-12 administration induces an increase of myeloid cells and the reactive microglia in the brain tumor microenvironment of the mice treated with combination treatment of CAR T cells and interleukin-12. Hence, to conclude, this study demonstrated that the benefit of CAR T cells and the local interleukin-12 combination therapy is multifaceted, as interleukin-12 administration affects the adaptively transferred CAR T cell efficacy, the endogenous T cell compartment, as well as the myeloid cells in the tumor microenvironment. The single dose intratumoral interleukin-12 is sufficient to sustain the CAR T cell fitness and also mediate complete immune responses in the mice with large established gliomas. Now, the impact of the present research shows that the use of local administration of interleukin-12 is beneficial in overcoming the barriers which have been encountered by CAR T cell therapy for glioblastoma in preclinical mice models. And also the authors had planned to translate this combination approach of CAR T cell therapy with single dose intratumoral interleukin administration into a clinical study for patients with glioblastoma. Thanks one and all for your patient hearing.
Thank you so much, Divya. That was truly an informative and edifying talk. I'm sure we all had a lot of takeaways from this webinar. I will now open the floor to the audience for any questions or concerns or opinions that you may have for Divya. Nupur has a question, and Vijay has a question. So Vijay asks, how local administration of IL-12 be achieved in human glioblastoma patients, and how does the diffuse nature of the tumor affect the response?
Now, actually, this study is done on preclinical mice models, and human trials are yet to be conducted. So I think it will be an intracranial implantation procedure which may be required to be tried. I mean, I don't think that is in the scope of this paper, but that is my opinion as far as the literature is concerned.
Does that answer your question, Vijay?
Yes, yes.
Okay. So Nupur has a question as well. She asks that, is it applicable to all types of glioblastomas? And because glioblastomas have different subtypes.
Yeah, now this is mainly conducted on the EGFR expressed type of glioblastoma. This study has specifically been done in mice models on EGFR expressed glioblastomas. And I don't have any, I've not seen on other glioblastoma expressed cases as of now.
One more, EGFR expressed, EGFR wild type or EGFR any mutated version?
No, they have not specified that, Nupur. It has been mentioned that it is just EGFR type.
Okay, thank you, Divya. Thank you for the presentation.
Thank you.
Okay, I have another query. So when there's a complete elimination of the tumor, so does it refer to only what is visible in the MRI, or the diffuse cells that spread out in the normal region of the brain are also included? Have they checked that also?
That you mean to say the histopathological
Yes.
diagnosis? I think in this case only MRI has been used to check the tumor volumes, whereas there has not been any histopathological analysis which is done in preclinical studies. Going further, I mean, they may plan for human clinical trials.
Okay, thank you.
Does anyone else have any questions for Divya in the audience?
I want to ask one question. So in this research, they've used IL-12. So can they use any other type of interleukins for this treatment or in combination with CAR-T cell therapy?
See,
Other types of
interleukin-12
interleukins?
mainly is a pro-inflammatory cytokine. So that is the reason it has been used as a combination therapy here. So,
Okay, so other types of interleukins can also be used, you're saying? Like here, specifically,
it's
like
not been
IL-12.
mentioned in this article though.
Okay, okay.
It has to be basically inflammatory with less of systemic toxicity. These are the main criteria which have been used here. That is why interleukin-12 has been used.
Okay, okay. Thank you.
I hope that answered your question, Shweta. So does anyone else have any questions for Divya? Okay. I don't see any questions in the chat box. So thank you so much, Divya, for that incredible presentation. So closing this webinar, I would also like to inform the audience that the next CellTalk webinar will be on the 5th of August, 2022. And Mr. Numair Arshad will be presenting on the topic slowing down glioma growth by knocking out MIR21 in mice models. With that, I conclude this webinar. Thank you all for your presence, and it was very nice having you, and hope to see you in the next webinar. Thank you so much.
Thanks, Aditi.